Hello, everybody. Dr. Dustin here. Welcome to another episode of the Dr. Dustin Show. And I got to say, today's topic is, it's a little interesting, right? How many of you guys have ever been given a diagnosis and for some reason the treatment just doesn't seem to hit? For some reason you still go to bed at night with questions like, does my doctor really know what's going on with me? Well, you're not alone, and probably your doctor doesn't exactly know what's going on with you, but that's part of the mystery and science and the art of pain management and really medicine in general. Tonight we have a full house, of course. We have Kevin back behind the scenes as usual, pushing all the buttons. Say hello, Kevin. Nice to see you. And he's saying hello. He's still pushing buttons. And then, of course, we have Evelyn in the chat tonight. And we actually have her helping us out a little bit too, doing a little exercise. So both of you guys, welcome. It's kind of interesting. Actually, we're all lucky to have Kevin tonight, given the events of this weekend.
What's up, guys?
Hey, there he is. If you guys were here on my live on Friday, or you got to see it over the weekend, down in Texas, we were having great weather the whole week, and beautiful, sunny, breezy type weather. And on Friday, I was like, yeah, well, we're going into the weekend. The weather's gonna be great. We'll see you all Monday. And then Monday, a torrential downpour, floods everywhere. I was like, oh boy, I probably should have gotten some more information before I anchored myself in the concept of good weather. Well, Kevin, do you want to tell your story? Because, like I said, we're all just glad that you're here today.
I think I'd started by saying I had a long shower, a super long shower.
Yeah, for those of you who don't know, Kevin drives a what many would refer to as a crotch rocket, and had some business to do up in Dallas. We're about an hour south of Dallas. And he got caught up in the rain on his way back.
The northernmost northwest corner of North Lake. And it was about a 2.5 hour ride back in a pretty good storm. Yeah.
You're not supposed to really ride motorcycles in torrential downpours, but
well, if you got good tires. If you got good tires. I had a lot of people that were just looking at me like, wow.
Yeah.
Wow.
It reminds me of that one time I rented a slingshot thinking it was a real vehicle.
I remember that.
Yeah.
He made me drive him everywhere until he got rid of it.
Well, it was my car was in the shop, so I'm thinking, no, this will be a fun way to get around. But what I didn't realize is actually on the inside of the vehicle, it says, this is not an automobile. It is a motorcycle. No roof, no air conditioning, no heat. And I think the temperature was like 30 degrees at the time.
What was that like, Ray?
It was a glorified go-kart.
Yeah.
Pretty much.
Yeah.
But a lot of fun.
It was very fun.
Yeah.
We did gain the nickname Batman and Robin, though.
That's true.
Oh, yeah. So that makes me Alfred.
There you go. You have to work on your British accent.
I'll try.
All right. Well, so tonight, again, we're talking about this concept of medical anchoring, right? Where you're basically making decisions on limited information. And not doing it so maliciously or even naively, with naivety, but with the very human thinking process that occurs so often with certain cognitive biases, right? So medical anchoring, it's so easy in pain management because a lot of our diagnoses are subjective, right? Pain is subjective. I used the word syndromal earlier today, meaning that what we're characterizing as your pain is really a syndrome of pain. If you've seen any earlier episodes where we talk about imaging, right? We did a whole podcast on MRIs, and does that help lend itself to diagnosis? And the answer is yes, but it doesn't necessarily give you a diagnosis, right? It can just sort of fill in the gaps, so to speak. And to illustrate that further, let's say you go into the doctor and, you have some pain in your neck, right? Well, your doctor will probably do an exam, ask a few other questions to help characterize the syndrome, the condition, and then you'll get on your chart a diagnosis of cervicalgia. Well, cervicalgia it tells us you have neck pain, but it really doesn't tell us much more. Maybe then you go get an MRI and you see that you have some degenerative arthritis type changes, right? Maybe a disc herniation, maybe some narrowing around some of the nerves. Well, congratulations, you just bought additional diagnosis of cervical spondylosis, which describes that degeneration. You got a diagnosis of cervical stenosis. And let's say you have a pain that's radiating down the arm, then perhaps that would give you a diagnosis of cervical radiculopathy, right? So these are all they're on a spectrum, let's say, of subjective to objective. Yes, you can have cervical spondylosis on the MRI and you can have it given to you on your chart as a diagnosis, but does it actually describe your pain, right? That's the question. Perhaps the most notable condition or syndrome that affects a lot of chronic pain patients is this idea of fibromyalgia. So we're going to use that as our case study tonight. Fibromyalgia. If any of you have been diagnosed or know somebody that has been diagnosed with fibromyalgia, go ahead and put that in the chat. Fibromyalgia. That's what we're talking about tonight. Fibromyalgia has been around for a long time. It's come by many names. It was first sort of recognized as its own entity in the mid-1800s. But it really didn't take the term fibromyalgia until around 1970, when people started using it more in clinical diagnosis. And then it wasn't even given formal diagnostic criteria till 1990, and then even that was revised in 2010. So it's definitely a syndrome that occurs, and trying to isolate it in a patient as its own diagnosis can be actually more challenging than not. Although it is its own diagnosis, and if you're ever wondering, does fibromyalgia really exist? You're hearing it from here first. As a pain doctor, yes, it absolutely exists, and it is absolutely its own entity, or so we think. And I say that because we don't quite know what causes it. That's part of the challenge too. The theories have changed quite a lot over the years. Some of the most prevailing theories as far as what could be causing or the pathophysiology of it to date would suggest that it's a neurotransmitter or neurochemical problem, or a central sensitization problem that occurs in the brain or the spinal cord. But it may also be on the level of the nerves or on the muscle as well. There's some theories that it could be an inflammatory condition, although that's sort of falling out of favor. Perhaps there's some issues with blood flow that go along with it. And of course, there's genetic factors as well. So yes, welcome to the complicated world of fibromyalgia. We don't quite know exactly what's causing it. The good news is we do have some medications that can treat it, and we have some studies to show that there's certain treatments that are good for it. But what happens when those don't work, right? Of course, not every treatment will help every patient with a certain condition. There's no 100% guarantee on anything, right? But is it possible that maybe you just don't have the right diagnosis, or maybe somewhere along the way you were given that diagnosis and then it just sort of followed you in the chart? That's what we're going to talk about tonight. And we actually have a little bit of an exercise that I put together here with Evelyn to sort of give you this idea of what medical anchoring is. But before we see it live, I'm going to give you some definitions here. Kevin, why don't you pull up the first slide? So this is a study that was done way back when. Pat Cross-Carey is one of the, you might call him, more notable voices in regards to describing certain cognitive biases that occur. And in this study, he went into the idea of what specifically medical anchoring is. Why don't we look at the next slide? So anchoring is the tendency to fixate on specific features of a presentation too early in the diagnostic process, and to base the likelihood of a particular event on information available at the outset. So that means like the first impression gained on the first exposure, the initial approximate judgment. This may be an effective strategy. However, this initial impression exerts an overly powerful effect in some people, and they fail to adjust it sufficiently in the light of later information. Anchoring can be particularly devastating when combined with confirmation bias, such as how you might diagnose fibromyalgia. So this is an old chart. This is how we used to diagnose fibromyalgia back in the early 90s and actually all the way up to 2010, where essentially you had to have whole body pain for, let's say, at least 3 months. And then you had to have a certain number of tender points on your exam. So you can see here all the little red spots on the drawing there. And if you had, I think it's 11 out of 18 positive tender points, you would meet the criteria for fibromyalgia. And the reason this was done at the time was to sort of standardize the approach to it. Because again, keep in mind, we don't know what really fibromyalgia is now, at least as a collective. We think we know. We have, like I said, prevailing theories. But back even before the 90s, it was really the Wild West. So this was an attempt to standardize research, diagnosis, that type of thing. Then in 2010, they realized, well, that just wasn't good enough because there's lots of other symptoms than just having tender points. And so they revised their criteria to include the questionnaires widespread pain index and the symptom severity scale. And we're going to include those in the description in case you want to reference them for yourself. There's a lot of questions that go into it. A lot of it looks more at, let's say, mental health changes, cognitive changes, other systemic side effects and symptoms that are that go well beyond the simple tender points and widespread pain. Again, the symptoms have to have been present for at least 3 months. Now, what often gets missed here, and this is the point, the patient does not have a disorder that would otherwise explain the pain. So really, it's a diagnosis of exclusion, in a sense. We want to make sure there's nothing else going on before we give you this diagnosis. But how often does a patient come to a clinic and they just check a history box? Well, I got fibromyalgia. And then the next thing you know, that's now given to you as a diagnosis that follows you through the chart. And you're still having all these pains, and we're still throwing all these meds at you, and all these trigger point injections and other injections, and you're not getting any better, and you're losing hope in the whole system. And what next? Well, that's what we're going to sort of go through today. So let's go into the exercise. Evelyn, are you ready over there?
Yep.
All right, cool. This exercise, so Evelyn's going to give me a patient story, one piece at a time, okay? And I'm going to sort of comment based on the information that I'm getting as we go. And you can see how this medical bias occurs throughout the encounter. So let's go ahead and get it started, Evelyn.
A 34-year-old woman has had widespread body pain for 2 years. She has fatigue, brain fog, poor sleep, and she was told she has fibromyalgia.
Okay, well, there you go. So right off the bat, you're going to get a diagnosis of fibromyalgia because, hey, I'm here to believe you, right? You said you have a history of fibromyalgia. You're going to get that as a diagnosis. And quite frankly, based on what you're telling me, that makes good sense. Unless I'm looking for that, why would I take the extra steps to give you the widespread pain index and the symptom severity scale and, work up other labs and this type of thing? You've already given it to me on the history. That's the challenge right there. That's sort of the immediate, well, hold on now. And I have a solution for this too. And remind me, I'm going to come back to that for a patient who's seeing a new pain doctor. Okay. But yeah, so far you're meeting the textbook. So, but we're not here to be stuck in our biases. We're going to learn more. So what else you got? What's going on?
She's been told her labs are normal. She's tried PT, yoga, antidepressants, and massage. She feels dismissed and hopeless.
Boom. Right? How many of you guys have been in that situation? The unfortunate part here is that this is where most things stop. You already told me that you had fibromyalgia. You already told me you did all the treatments for fibromyalgia. This is where the confirmation bias comes in. Now I'm thinking, okay, somewhere along the way she got diagnosed for it, right? Somewhere along the way she got all the appropriate treatments for it. But unfortunately, and perhaps all too often, this patient did not respond to these treatments. And so now they're here in my clinic. That's the unfortunate part. So where do you go from there, right? Because I think many of you might find, well, this is where you get referred to psychology. This is where you get referred to psychiatry. This is where more of the mind-body medicine type stuff kicks in. Not to dismiss that, again, as a potential treatment option. It very well may be. But again, the risk here, which is what we're talking about, is that we've totally missed the concept of the diagnosis. Is it the right diagnosis? And, in a lot of clinics too, you don't see the same provider like every visit, right? You may see the doctor on the first visit. You may see a nurse practitioner or two on the second or third visit. Maybe at some point you circle back and see the doctor. And then if, that doctor is being covered by somebody else, another partner in the group, or he's on vacation or she's on vacation, and whatever the case may be, right? So, but they see it on your diagnosis list. Then it just keeps on propagating the let's say an inappropriate treatment for an unknown diagnosis. So that's what we're trying to overcome. So go ahead and hit me on the next one. I want to know more information, Evelyn.
She also has morning stiffness that lasts over an hour. Her hands swelled sometimes, and she has a strong family history of autoimmune disease.
All right. Well, things are picking up here. Things are getting interesting. So now, with perhaps some additional questioning, really trying to tease out what's going on. And some of these symptoms are going to show up on the symptom severity scale or the widespread pain index, which is good because it's going to include that perhaps in the overlap of the diagnosis for fibromyalgia. But unless we rule out those other things, remember in 2010, that was part of the criteria, is making sure that none of this other stuff could be causing it. So now I would change my potential diagnosis to include, let's say, an inflammatory type arthritis, which would then dictate a different set of workup, lab values, maybe x-rays, and potentially even a referral to a rheumatologist at this point. And what else you got?
She also gets recurrent mouth ulcers and has had episodes of eye pain with redness.
Okay. Well, these are not symptoms that are typical for fibromyalgia. And, the same thing is true with, let's say, Ehlers-Danlos syndrome, EDS. A lot of the same symptoms with EDS can overlap with fibromyalgia. A lot of the same symptoms with inflammatory arthritis or systemic inflammatory disease can overlap with fibromyalgia, even irritable bowel syndrome. And so it's, again, important to keep all those in mind and keep an open mind, right? The big thing with cognitive biases, a lot of these studies I noticed were done on emergency department physicians because they have a very short amount of time to come up with a diagnosis, right? You're having an emergency, maybe you're in 20 out of 10 pain, maybe your vital signs are unstable, whatever the case may be, that doctor has to get to you quick, figure out what's going on quick, right? And of course, as a pain patient, in working with your pain doctor, you want those diagnoses to be quick too. But I would caution you in that sense to sort of slow down. Let's really make sure that we know what we're talking about. So again, we can give you the right treatment. Kevin, why don't you pull up the next slide? Because I want to show everybody exactly what could be going on, right? These are all the conditions. If you look at the left-hand column, we have several categories: inflammatory and autoimmune disease, endocrine and metabolic disease, infections, neurologic conditions, multiple sclerosis. I have had a number of multiple sclerosis patients that present as fibromyalgia, interestingly enough. Medication-induced muscle pain, statins are, of course, being a big one there. Psychiatric and central sensitization overlap. So again, mood disorders, trauma history, sleep disorders, chronic stress syndromes, basically anything that flares up the autonomic nervous system can definitely cause things to hurt more. The next slide, of course, is the rest of that, where you can look at additionals. Kevin's pulling it up. So the point of that is that there are multiple conditions that could be causing fibromyalgia, mechanical musculoskeletal issues, sleep disorders, and, of course, malignancy, multiple myeloma, metastatic disease, these types of things. There's going to be red flags that your doctor should be looking for. So hopefully that one's not missed, but it is important to realize. And because it's on here, you can always go back and screenshot it for your own reference. But yeah, this is kind of what we're saying. So, the truth is this applies to nearly everything in pain management. Right. So often I hear patients come in and say, I have a herniated disc. Well, that right there could be medical anchoring. That right there could be setting your physician up into a cognitive thought process that may or may not be the cause of your pain. And so fibromyalgia, though, is a little bit more unique because, disc pain is pretty stereotypical. Fibromyalgia is a broad spectrum of symptoms. And so if I were a patient, how would I best help myself? I'm not saying that I would ever lie to my physician. Because, there's two people in life actually there's three people in life you don't lie to. That would be your lawyer, your doctor, and your priest, right? But I think we could be doing harm to ourselves as patients if we step into a world and we tell our doctor, I have a history of fibromyalgia. Now, unless you already went through all the different diagnoses and all the different testing and you saw rheumatology and you had all the blood tests and, it was really quite clear you have fibromyalgia, then definitely, But if somebody, gives you an offhand diagnosis, you go to the emergency room, right, where coming up with that diagnosis in that moment really is not possible. But then that sticks with you forever. Well, a doctor told me I have fibromyalgia. Well, just hold the brakes. Let's just, tuck that away. What you might do is bring up to your pain doctor, hey, at some point, somebody told me they thought maybe I had fibromyalgia. What do you think? Right? Ask some open-ended questions. Ask questions like, what else could we be missing? What else could this be? Because I know fibromyalgia, can affect a lot of different body systems. It can give you a lot of different symptoms. But what I don't want to do is go down a path under a label that may be incorrect. That's sort of disenfranchising, to say the least. Make your doctor work for it, especially if you haven't already gone through the whole workup at that point. And even if you meet the criteria for fibromyalgia, let's say on the widespread pain index or the symptom severity scale, you still have to rule out other conditions in order to get that diagnosis. So don't forget that. But yeah, I think that's a huge thing in pain management, this idea of falling into this trap, so to speak, of anchoring ourselves into certain labels. Not only can it give you the wrong diagnosis, but if you even anchor yourself into the idea of, well, I have degenerative disc disease, I have a disc herniation, which means forevermore you're going to have this belief that that is where my pain is coming from, even though it may not be. Or I'm going to be chronically injured, or I can't move the certain way, whatever the case may be. Pain is so subjective, and I'm not saying that we need to throw out all labels. We need to have a label, but we need to know why we have a label. And I think that might be the lesson for tonight. Biases are real, and they're not malicious. It's a way that we can work through the system efficiently, right? But when it comes to chronic conditions, where it's not a black and white diagnosis. It's a syndromic diagnosis. Then we really want to make sure that we have all the best information possible before we identify a label and stick with it.
So here'd be one question. Would there ever be a safe space where it'd be good to anchor yourself to a label? Anchor yourself to, a condition? At least you have a starting point. Perhaps.
If you're seeing a pain doctor for the first time, I would leave it open-ended. Yeah, I think the more that you ask or you put your doctor into position of answering yes/no questions, it's going to be really easy as that doctor who has to flip through patients every 5 to 15 minutes to say yes, no, next. And quite frankly, if I was a patient dealing with pain for more than 3 months, already maybe gone to the emergency room, already saw my primary care doctor, already tried some medications that, aren't getting me better. And then I had to wait another 6 weeks, 2 months to get in with a pain doctor. And by the way, pain doctors are specialists. Okay. Like we go to school for extra time. We do extra training. We take more tests, right? Like I don't know, is it every year, essentially, I have to take, 200 board questions a year to maintain my certification.
Wow.
So make us work for it. I mean, because again, the risk is that you come in and say, I have a history of fibromyalgia. Oh, okay. Well, let's get you treated. That's easy to do.
Down to business.
Right.
What you already know you want.
And if you've already gone through the rigmarole of getting your diagnosis, you already saw rheumatology, you already had the blood work and all this stuff. Okay, fine. Like, let me know that. I'm also going to request records, by the way, at least from your last pain doctor, but if appropriate or indicated, your rheumatologist, things like that. I want to prove to myself, and your doctor should want to prove to themselves that, not that we don't trust you, but again, you didn't go to school for this. So there may be labs that are missing. There may be imaging that is missing in order for us to give you the proper diagnosis. I don't think there's anything wrong with expecting that, but that's the goal for all of that, is to improve your communication with your physician. Keep the questions open-ended. Don't give them any information that, let's say, could put them down a road. Mm-hmm. Right? Nobody ever comes to a pain doctor and says, oh, I've had problems with opioids.
Right.
I'm going to find out, because that's usually how it works. Your last pain doctor, I'm sure, will have something to say about it, if you did or you didn't. But we don't do that as patients, but then we will go and tell them, well, we have a diagnosis of fibromyalgia. There's nothing wrong with that, but again, you could be putting yourself into a position where you carry on a false diagnosis. Yeah.
Makes good sense.
It's a simple lesson tonight. I mean, nothing too complicated about it, but I think it's an important one, not only in how we advocate for ourselves as patients or family members advocating for our family members as patients, but it's okay to make your doctor work for the diagnosis, especially if you're getting a second opinion. Don't tell your second opinion necessarily everything that you already expect it to be.
Let them go ahead and do the work.
Let them do the work.
Right.
That's the value of the second opinion.
Right.
They may get tests that you already didn't do. They may have an entirely different perspective, but as soon as you put them into a bucket, well, now there's confirmation bias, there's anchoring bias, there's all these other types of things that, well, that sounds right. Yeah, I agree. And part of that is also just how we're tested. Our board exams. A lot of our questions are like, well, patient has A, B, and C. What is the answer? A, B, C, or D? B. And the clock is ticking, right? So we're sort of conditioned to move quickly. I don't want to say shoot from the hip, but we want to be as accurate as possible. I think the American Academy of Medicine estimated that patients were given the wrong diagnosis about 1 in 20 times.
Wow.
1 in 20 times. That's not specific to any specialty. And I don't know how that's reflected in pain management. But I imagine it would be significant given, again, the subjectivity of pain management. Like I said, we don't even really know what's going on with fibromyalgia. We have treatments that we know works for fibromyalgia, but again, without knowing that it's not the 40 other things that were on the screen there earlier.
Right. And so you have 5% of people taking the wrong medicine.
It's very important. It's very important to have the right treatment for the right diagnosis.
Right.
Otherwise, you're coming at everything with a sledgehammer, and then there's inefficacies, there's side effects, there's growing frustration, there's more pain, there's more suffering. And so, I would want to make my doctor work for it.
Right. And you know, when you really think about it, you know who's more than likely to leave that bad review? That 1 out of 20 that didn't get the proper treatment.
Well, sure.
Mm-hmm.
Yeah. If I was a patient and I was convinced that my doctor did everything he or she could to get me an accurate diagnosis, and the treatment didn't work, I'm cool with that. I can accept that. I can say, okay, well, clearly, my doctor's working for me. We're turning over every stone. There's effort being put in. I feel cared for. I feel listened to. I'm just that, small percentage of people that doesn't respond to treatment will find something else that works. But I definitely, as a patient, I would feel like sort of jerked around, pushed around, dismissed, not listened to, unheard, if I'm just telling my doctor what's wrong with me and he or she's not doing anything to confirm that. Yeah.
So what do you think a one word for that is? Unanchoring? Is that even a word? Unanchoring?
Yeah, I mean, you unanchor yourself in whatever it is that
you're anchored to.
I don't know. Keep an open mind.
Mm-hmm.
Keep an open mind. Like I said, pain is weird. Pain is weird. It's not like you have it or you don't. Well, pain, but it's not like we can tell you, well, you have cancer or you don't have cancer. You have a fracture or you don't have a fracture. That is definitive. That you can sleep with at night, regardless of the outcome almost. But what's causing my pain? That's the mystery. Like I said, even when you give a diagnosis of cervicalgia, right? Neck pain. There's so many things in the neck that could actually be causing that pain. But that's, again, how our system is sort of designed, is set up. So even as something as simple as neck pain, it could be the muscle, the soft tissue. It could be the facet joints, the discs, the vertebral bodies, the nerve endings or the nerve roots, the spinal cord. Could be coming from the brain itself. Or just referred from another part of the body, right? Posterior headaches, occipital headaches. So there's so many different things, like I said. Even heavy metal poisoning, something as esoteric as that. So, that is the problem in how we diagnose things. Pretty much everything on your chart is going to be a syndrome. Even fibromyalgia syndrome. Mm-hmm. Cervicalgia doesn't tell us, what's causing your pain. It just tells us where your pain is.
So would there ever be a case in point where anchoring could remotely be good, or is it just flatline altogether, like a no-go?
Yeah, I think we should always keep an open mind. I think the idea of having a working diagnosis and then just working with that. Like, let's say you suspect a patient has fibromyalgia syndrome. Okay, put the diagnosis code in the chart. That's an accurate description. Patient is meeting the criteria for fibromyalgia syndrome. You might also document in there for future reference. We did this blood test. We did that blood test. We did this imaging. We ruled out this, that, and the other. As of today, pending further evidence, this is what we're working with.
And I'm asking that in a situation because, take for instance, if I were to go in and I have my medical history and I say, hey, in the past they've been treating me for A, B, and C, and I've been getting some relief to some degree. I mean, that's already stating where I stand and what the past diagnoses were. Is that kind of the same? Or just let them figure it out? Because on some way, I'd like to think that if I'm already getting some sort of help, and hey, I was at a level 10, now I'm at a level 7. I'd really like to get to a level 5 or 4, but
Sure.
this is where we've gone and been.
No, see, that's different, right? Now
Okay.
you're bringing to me the path that you traversed
I
to get
gotcha.
to this point.
Right. Okay,
And that can
okay,
speed
okay.
things up.
Right.
And as a patient, I don't always want to repeat everything every 3 months to try to figure out. No, it's like, no, let's take the information we have and build on it.
Mm-hmm.
But I'm here to tell you tonight that having a diagnosis of fibromyalgia really doesn't tell us much. Now, the path that you took to get there should tell us a lot.
Right.
If it's an offhand diagnosis, let's say that your primary care physician gave you because your primary care physician is recognizing certain patterns, there's nothing wrong with that. Again, take that information, tuck it away. But the risk that you have of carrying that on to your pain doctor now and say, hey, doc, my new pain doc, nice to meet you. I have a history of fibromyalgia. Boom. It's so easy right there in that moment just to say, okay, well, let's treat your fibromyalgia. Here's a medication. When in reality, we could be missing inflammatory arthritis. We could be missing, a systemic inflammatory disease. We could be missing EDS or any other number of those things on the charts that you had up earlier.
That makes good sense.
So, but if you came to the table and say, hey, so I've had this pain for a while. This is what I'm feeling. These are all the labs that I did up to this point. This is all the imaging that I did up to this point. Bring your medical records and say, hey, where do we go from here? Nice open-ended question.
Right.
Now
I gotcha.
I'm forced to review and critique and give you a diagnosis based on what I think is going on, and then I may recommend additional workup, but we're not repeating anything at that point necessarily.
Are you guys getting that in the chat? The plan of action and the way to present this, or the way to communicate it?
Yeah. It all comes back to communication. And especially in pain management, because it's not something that we want to gamble with. We want relief as soon as possible.
Oh yeah.
And so, and then, making sure your pain is treated in the meantime, of course, that's going to be a part of it. But where are we getting in the chat? Anybody? Is this vibing with anybody?
I see. So true, Kevin. So true.
Kevin, you are true. Yeah. Keith says, it's like the diagnosis of last resort. If docs can't figure it out, bam, congrats, you have fibro. Yeah. Maybe, maybe not. But again, you want them to work for it. You want them to work for it. Love the suggestion. Someone mentioned it helps to take the yes/no answer off the table. If they say either yes or no, then we have a follow-up of why do you think that? Exactly. Like I said, if you have a board-certified pain management physician, we have to take board questions every quarter. So we should be able to speak on some level, at least, to walk you through the diagnostic process. But again, our system is not set up for that in real life. Our system in real life is, oh, I'm sorry, you said you had a herniated disc? Let's get you set up for an injection. Oh, I'm sorry, you said you had fibromyalgia? Let's throw some duloxetine on there. See you back in 2 weeks.
Wow.
Right. Sometimes you got to do what you got to do with the resources that you have. But I'm just saying for myself, if I was a patient paying a specialist that I waited to see.
Right. Yeah. That you don't want to have to wait to come back again and start the whole thing over again.
But bring your records. That's going to speed things along. And if you don't have those records because you didn't go through the path to get those records, because you didn't do the labs or didn't do the imaging, okay, well then don't tell them that you have fibromyalgia.
Right. Say,
someone once told me or suggested I might have it. What do you think? That would be the way to do it. Let's see. Yeah, same. We can't, just like with the ACE scores, we can't lie, but at the same time protect ourselves. Yeah. And yes, if you haven't seen our episode on ACE scores and how that can be used against you, I might check that out. But yeah, it's similar to the same thing, right? It's not to say that ACE scores can't augment your pain experience. It's not to say fibromyalgia can't augment your pain experience. But because of the very real possibility that there's a, let's say, more tangible alternative diagnosis that's just sitting out there waiting for the grasping, don't shortcut your doctor. Don't shortcut your doctor. And again, your doctor should know all this and do all these things. And a lot of doctors do. Not everybody. And as a patient, I just want to set myself up for the most possible chance of success. Let's see. Jamie says, we have more questions than answers when it comes to fibromyalgia, and depending on the doctor you see, will have a different perspective. Autoimmune or neurological or endocannabinoid deficiency. I love that word, endocannabinoid. Yes. Yeah, exactly. That is also part of the nuance of fibromyalgia. As I mentioned in the beginning of the show, we really don't know what the pathophysiology is behind it. Like I said, we have several theories, some prevailing more than others. And generally speaking, the treatment may be the same depending on how we understand the pathophysiology to be, whether it's certain medications or certain types of therapies and whatnot. But again, you have to know that it is the right diagnosis so that you can give the recommended treatments the best opportunity to work. Let's see. Yes, duloxetine works for mental health too. That's true. It is a selective serotonin and norepinephrine reuptake inhibitor. That's what SNRI is what duloxetine is. Also, milnacipran is another SNRI, perhaps a newer version of duloxetine. Both of those are FDA indicated for the treatment of fibromyalgia. The other one is pregabalin or Lyrica. And then there's another type of medicine that was basically a rebrand of cyclobenzaprine that is dissolvable under the tongue, that is indicated for the treatment as well of fibromyalgia. Of course, there are a lot of exercise-based treatments that have been proven effective for the treatment of fibromyalgia. The more you move, the more blood flow you have, the less sensitization you have with regard to your nerves. So there may be some theories there that show why it works. And yes, cognitive behavioral therapy and mental health interventions have shown to be quite effective too. So not to diminish those things. But again, we want to make sure that, again, with the amount of investment and time and resource that goes into a lot of these treatments, we just don't want to be barking up the wrong tree.
Keith said something pretty interesting. I didn't know. Is that true? They don't give medicine for fibro patients?
You know, a lot of doctors don't give pain medicine for anything anymore. No, I don't know that that's true across the board. Generally, in my experience, if you have let's say a pro-opioid pain doctor, that may be a treatment option for you. Whereas if you're working with an anti-opioid pain doctor, let's say for the purposes of treating chronic pain, then yeah, they may not give it to you. But going back to the whole opioid discussion again, generally speaking, at least this is what we're being educated, and the research is pretty clear. I think also opioids are just not recommended for long-term non-malignant chronic pain.
Sure.
But again, this is where clinical judgment comes in, because there are patients that benefit very greatly from it. And so how do we protect those patients, making sure that the right patient gets the right treatment? Right. That's all part of the challenge. Yeah. Because if you remember, one of the things that could mask as fibromyalgia is opioid-induced hyperalgesia, which I know is a whole nother controversial subject in and of itself. But it does exist. And the only way that you would know, it's not the majority of cases, for the record. It's a minority. And we learned in a prior podcast how that can be used to manipulate and control and negatively affect patients. But no, the diagnosis is treatment. If you reduce your opioids, then your pain should get better. If you go up on the opioids and your pain gets worse, well, probably you could have opioid-induced hyperalgesia. But again, I understand the controversy there. But if you really truly did have that, it would mask itself as fibromyalgia. So that should be part of the conversation there. Yeah, Jennifer said it's very difficult to get pain meds with a fibro diagnosis, from my experience and hearing from the community. Yeah, no doubt. Probably that's true for most conditions, would be my guess. Let's see. Any diagnosis shouldn't be the end of all investigating, should it? In pain management, I don't think so. Pain management's pretty subjective. You can have certain objective things like, okay, let's say you have bone-on-bone arthritis in your knee, and it's like, oh, your pain is only ever there when you stand up and bend your knee. Well, holy cow, it's probably the bone-on-bone arthritis in your knee. I think we can calm down everybody and treat that, right? Maybe you need a knee replacement or something like that, and then magically your pain gets better. But no, even still, you want to keep the mind open to the possibility of lumbar radiculopathy, right? Or sciatica. You can have an L2, L3 pinched nerve, and that dermatome goes right through the anterior knee. You can experience that as knee pain. All indications may point to knee pain, but actually it's coming from your back. I have a few patients actually, just thinking about that in the last couple of days, that fits for.
I'm kind of curious. So you said something before about like a cannabinoid system or something cannabinoid. What was that again?
Oh, the endocannabinoid system.
Oh, cannabinoid. Okay, right. I thought you said
right.
like cannabis or something. Well, even then, so is that one of the treatments that you've seen, in your practice for fibromyalgia or certain types of pains? Because, I don't know if any of our viewers are outside of the state of Texas, but we have a lot of like CBD shops and stuff everywhere that just popped up out of nowhere. So is that one type of treatment? I know I was looking too at one of the books on Katie's show. It literally says like cannabis is medicine. Yeah.
No, absolutely. Yeah, I have that book. I think thanks to somebody in this chat. But yes, the endocannabinoid system is essentially a path of neurons, receptors in your brain, spinal cord, midbrain, just like other parts of your brain that, let's say, carry serotonin or dopamine, norepinephrine. Well, we have an endocannabinoid system as well. And actually, fun fact, Tylenol, one of the reasons why we think Tylenol works is because it stimulates those same endocannabinoid receptors.
So Tylenol has trace cannabis in it?
I don't know about trace cannabis, but it definitely stimulates those receptors.
Interesting. Yeah. Very interesting.
CBD and THC, I am pro CBD and THC, especially when it can help someone with their pain. Obviously, that's yet another controversial topic. I love pain management for this reason. You just can't get away from the controversy. Any sort of diagnosis, controversy. Any sort of treatment, controversy. Not only from the patients, but also from the government your peers.
Oh yeah,
and God. It's a beautiful way to spend a life studying the ins and outs of pain. But no, I would say it's definitely going to vary state by state, country by country, how you can get your hands on proper CBD or THC products. But yeah, I think it's definitely something that perhaps could use some more research that would show the governing bodies why we need to legalize it on some maybe greater scale, or formalize its production and distribution so that we can make sure that there's no, adulterants that may get in and cause harm. So yeah, I know officially I would never recommend someone to buy something off the street. I think I would never do that. I just don't trust whatever it is that I could be getting. But
sure.
But no, there are companies, and depending on the state that you are, that have, let's say, third-party overseers that test the products, make sure they're pure and all that good stuff. So yeah, if it works for you, man, more power to you. Yeah. But in the state of Texas,
yeah,
it's a little different. We have THC-free CBD products, so you can still get the effects of CBD at least, and that's legal. You won't fail a drug screen and things of that nature. But if you're coming from California, I'm sure it's quite different there. Yeah. Wish every doc understood that marijuana could be a tool for our toolbox. Just saying. Yeah, man. Like, for real. For real. I mean, everybody complains about opioids, but like, what's the effect of marijuana?
Mm-hmm.
Everybody knows without a doubt the damages of alcohol on our society.
Oh, yeah.
Right? And even the self-medicating for pain management patients using alcohol. But, you know, that has way more effect on I think a national scale. I'd love to get into the numbers of that more, perhaps on another episode. But, yeah, it's very interesting what we promote and what we demote in this country.
What makes the most money and what you can't grow here and what you can legalize. And, oh, yeah.
Jennifer says there are some super knowledgeable and helpful medical dispensaries in Illinois. Well, there you go. Cool. Yeah. Yeah, Lugnut says it's important to get good quality CBD. Don't get the gas station stuff. Yeah, no, that's true. Invariably, I will have patients that do that. We call them head shops, or I guess gas stations too, depending on where you're at. But it'll say one thing on the label, but then your drug screen will say another thing. And so, yeah, don't get yourself into trouble. Make sure you know what you're getting yourself into there. Cool. Well, yeah, hopefully tonight was, helpful. And again, this just comes in full circle with what we're trying to do: empower, educate the patients, yes, other doctors, but also optimize the communication that patients have with their doctors so that you're not getting shortchanged. And you give yourself the best possible chance to get the best possible treatment for you. And that's what this is all about. If you haven't already, don't forget to leave a like on the actual video. That's super helpful, as always. And yes, simply bringing up the term anchoring is important. So thank you again for joining us tonight. We have a great episode tomorrow with Jose, the idea of degenerative arthritis and the role that plays in your treatment plan. We'll see you tomorrow. Have a great night. Bye-bye.